And I'd like to start by introducing to you why many, many years ago I decided that I would like to become dedicated to medical education. And the reason I decided that as a student, because I realized this. This is, in Portuguese, the traditional textbook. And the traditional textbook comes always in the same format. You start by knowing the diagnosis, because that's the title of the chapter, am I right? So you know the diagnosis as the patient comes in. Then it follows that you have the epidemiology. How many people are they and how do they look like? You have the physiopathology. How do they come about in developing that disease? You have the clinical manifestations, the lab exams, and finally, the therapy. Next chapter will come exactly in the same format. Diagnosis first, and then you have the second thing. Now, maybe your book is organized in sections. Each section has a little different color, but again, the same sequence, right? They come in different colors, and you have all that, but you start by looking at the diagnosis. And then epidemiology, physiopathology, the clinics, the blood tests, and then therapy. And I realized as a student that the teachers were on purpose making my life hard, because patients don't come to me like this. They start by presenting the clinical grounds. And I don't know where they come from. Everything can come through my door. So I need to consider everything. Therefore, I need to make a resume in my mind of all the different sections of clinical grounds that I learned in different conditions and try to establish the commonalities and the differences. Once I consider that, I then, if I don't recognize immediately a pattern, I turn to physiopathology to try and understand it. That's even how heavy experts and established experts work. If you don't recognize a pattern, you think about it physiopathologically, what could it be? Now, if you don't recognize that, you then consider the epidemiology. Now, some things are common, some things are rare, among the ones that I have considered. I then put on a number of diagnostic hypotheses. I revisit the clinic. I go back there to ask the proper things, to make the difference, come down to a short list of diagnostic hypotheses. Now, do I think of lab tests? Finally, I have a diagnosis and I consider therapy. So why would teachers make my life hard as a learner in presenting me everything in a different direction as reality asks me to deal with it? They are expecting me, the learner, to do the real difficult stuff, putting it together, considering similarities and differences, and then applying it to practice where my patients do not use the words that my teacher taught me. They use their own words. I have to interpret that. I have to come to conclusions myself. So this is something that actually motivated me to try and do a better job. And I think we can all do a better job. And in order to do that, we need really to consider the clinical context. That's why students came to me. I train many more pre-graduate students and postgraduate students. They came to the medical school because they want to be doctors. They don't want to be biochemists. If they wanted to be biochemists, they would go to biochemistry. They don't want to be immunologists. They want to be clinicians, applying immunology, applying biochemistry as needed to resolve their problems. And therefore, it is expected certainly that I gear my teaching to achieve those goals. I did my PhD in the UK, and if I was to use only one thing that I learned there, the most valuable thing I learned there is a common saying. It's almost like, how would you say it? Common language is a proverb or whatever. It's not even a proverb. It says like this: everywhere you're about to start a journey, be it real, be it a figurative journey, you should answer 3 questions before you start. The first question is, where do you want to get? The second question is, how do you get there? And the third question is, how do you know you got there? And I always tell my students, this is almost my first slide, and forgive me if you feel it's inappropriate for you, but I feel it should guide everything. I tell my students, they are usually in their 20s, that for instance, they should apply this to decide to whom they should get married. Do you want to get rich or do you want to get happy? Right? That's how you decide. How do you get there? How are you going to select? But it's always the same thing. Do you want to get married? What for? Do you want to work? What for? Are you going to start this course? What for? Are you going to start writing a module for this course? Where do you want to get? Then you might know how to get there. So the first question is, where do you want to get with this? Now, EULAR gives us an answer that is quite different from traditional textbook. The traditional textbook comes from the principle that if you know everything, you know what to do with it. Wrong. How many of us have met colleagues of ours that are medical encyclopedias? They know everything. They could tell you in which page the information is. Can they apply it to patients? Not always, can they? Sometimes you have a wonderful clinician that doesn't know that much, but he knows how to apply it. One of the most influential people in my experience was, my supervisor in the early days of internal medicine, and he used to tell us, of medicine, I only know A and B, but I know A and B very well. Then I can build the rest of the words on it. And this makes a tremendous amount of sense, I believe. So the first question would be, where do we want to get? Now, if we accept the guidelines from EULAR, when they tell you the author's manual general guidelines, they tell us the following. The content should be adapted to the learner level. Trainees in their very last year of training in rheumatology, as well as established practicing rheumatologists in Europe. So we should be targeting this level of knowledge and practice. It's actually underlined that they are practicing rheumatologists. It doesn't say they are academic rheumatologists or they are researchers in rheumatology. They are practicing rheumatologists. So from that point of view, how should we gear our methods so that we get to that destiny, so that we get to where we want to get, right? And we decided we want to get. Now, there is some food for thought that I, will share with you. This is a quote from this paper. Our job as educators, and we all are educators in this room, is to continue to evolve our teaching methods in the hope that our students become more efficient and more accurate problem solvers. We don't want them to know everything. We want them to be capable of mobilizing the necessary knowledge in a way that resolves problems. Not that they know everything. We don't want them to be copying machines, copy and paste guys. We need them to be able to mobilize the right knowledge in the right time, in the appropriate way, so that the end result is what you need. So you need to allow them to experience that. You just don't give them the knowledge and expect them to use it in the most appropriate way. Now, what knowledge should we give them? Now, this is another food for thought for a much less authoritarian person, and I'll be back to that. Now, if you decide that this is the learner that you are trying to build, the practicing one that is capable of resolving problems, we can go back to Bloom's taxonomy and try to decide at which level of the pyramid do we want to focus our intervention, our teaching and learning. Now let us see, who would believe that it is enough to achieve that, to remember facts? Could you raise your hand if you believe that this is enough? No one, obviously. Who would believe that it is enough for you to understand things? You don't only remember, you understand them. So maybe you are capable of taking your knowledge and adapting it somewhat to the changing conditions of the particular case that you have in your hand, because you understood, not only because you can recall. Is that enough to be a clinician? I don't think so either. Who believes that we need to get at least to the apply level, meaning use information in new situations, execute, implement, solve, use, demonstrate, interpret, operate, schedule, sketch. These are verbs that can actually indicate, they can be used as objectives. You are capable of doing things. Understanding something is not of any use in itself, is it? you need to apply it. So you need to be able to demonstrate that you can use it. Who would agree that we need to focus our teaching in at least this level, applying? Anyone? At least. Below that is just means of getting there, right? Well, you can't really be a good clinician without knowledge. We agree with that. But it's not enough. So you need to be able to apply it. Should we expect our learners at this level to be able to analyze data, analyze information, meaning draw connections among ideas, differentiate, organize, relate, compare, contrast, distinguish, examine, experiment, question, test? These again, active verbs to define objectives. Should we have elements of this in our teaching? Who would agree with that? To be able to analyze, isn't it clear that a clinician needs at least to be able, for instance, to analyze the evidence, to see which one is applicable? You just don't take the evidence because I say so. I usually tell my trainees that you will fail your exam with me if you tell me that this is this way because I said so. Right? I don't take that. I can be wrong. And I need you to be able to understand and be critical about the information that you got. You know, I truly believe that we need also to gear our education to this level. Be capable of analyzing data. We actually have in the full online course one chapter dedicated to analysis of evidence, to a critical appraisal, because that's absolutely essential, I think, particularly in these times when information comes in such a large amount and in such a high pace. Should we be able or help them to evaluate, justify a stand or decision, appraise, argue, defend, judge, select, support, value, critique, weigh? Should we expect our trainees to be able to do this? Of course. That's how you decide what intervention you're going to do. You know, that's how you decide what investigations you're going to do. You need to compare, you need to judge, you need to appraise, you need to present your arguments to someone. So I think that, you know, over here to create something is already more in the research level. We are not asked by EULAR to create researchers, but I believe that we cannot read those guidelines without being convinced that we need to be at this level. Apply, analyze, and evaluate. So we need people not only to know, we need them to be able to apply their knowledge. And actually, you know, if we look again at these three guidance, if this is where we want to get, we need to now decide how do we get there. What kind of learning opportunities should we give our learners so that they develop? And again, I think that's, you know, at least in my mind, we need to change our verbs from teaching to facilitate learning, because actually I don't think that I ever taught anyone anything. People learn. Occasionally, I facilitate that. I try to facilitate that, but I don't teach anyone. They learn if they want, and they don't learn if they don't want. So let's make a difference here and give responsibilities to the teacher and to the student, because, you know, they are not there to be taught. They are there to learn, and maybe I can make it easier. So how do I get there? If I want to reach this level of performance, I need to have learning opportunities that will gear and, you know, target this level of performance. So EULAR has given us for the modules, and I was very much involved in the design of this package, a number of conditions to do it, namely learning objectives. And if you read through the instructions, it tells you that the objectives should be written with active verbs, things that people can do and they couldn't before being with you. That's the objective of what we are doing. We have a written main text. It's still not very much geared from practice to, departing from practice to, again, outcomes in practice. We have in-depth discussions to show people that there is more than what we can convey to you in our general review. We have two interactive typical clinical cases, and again, trying to put the emphasis on the practicalities, on the practical aspects. And we have an assessment section that consists of two sets of questions, and this assessment is the main topic of our meeting now. So The importance of clinical context for the learner in terms of learning is, of course, decisive, I think. If you want to be a clinician, you need to practice as a clinician. You need to consider your options as a clinician, not as, say, a textbook or a photocopying machine. But it is also decisive that we intend then what kind of knowledge we need to be used. And the concept I'd like to convey to you is this one: is knowledge of any use until it is applied to someone's benefit. And if we look at this from the point of view of clinical medicine, there's always an image that comes to my mind. Who amongst you has learned in your school about the cycle of Krebs? Have you learned about the cycle of Krebs? How many amongst you have used ever that knowledge to take care of a patient? Anyone? 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 No one has ever used the cycle of Krebs to take care of patients. If this is the case, the question should be, why should students learn about the cycle of Krebs? It's not useful for them. Maybe if I become a biochemist and a physician working in the lab as well, I will need to learn that again. But the idea is that the information we give should be useful to what we are trying to learn how to do. I don't want knowledge just because of itself. I want knowledge that is useful for me to solve problems. And because I want to be a specialist, the level of knowledge I need is much more higher in the ranking than the knowledge that an undergraduate student needs, but still is to solve problems in the way they present to me. So it's a more sophisticated level of knowledge. On the other hand, let's say, if you want people to learn how to do things, you go back as much as 3,000 years almost to learn with this man, right? Confucius, tell me and I will forget. So, the teacher comes on to the podium and speaks at me. It goes past, right? Some things I will catch them in the air. If you show me, I may remember, and if you involve me, I will understand. So hopefully, if I get involved in solving clinical problems, I will understand how to deal with that, what is the information I need, and how I should deal with it and manage it so that I can resolve problems. There is a very beautiful quote from a good friend, again from the UK, I don't know why. He is an expert in evidence-based medicine, not a physician. And he has this wording that I quote him. He doesn't quote himself. He says, the objective of medicine is to transform information into knowledge, and then knowledge into wisdom. Evidence can only help you in the first half of the way. I think this is so true. But again, we are giving people information in the hope that they, by themselves, transform it into wisdom. Come on, guys. We can do better than that, I'm sure, right? We can share some wisdom and the ways we get there. Okay. Now, if we then know, how do we know that we got there? We decided that we want them to be, I hope, problem solvers. We try to teach them in context so that they learn how to apply knowledge and solve problems. How do we know that we got there? It's obvious, isn't it? We ask them to solve problems, right? That's the only way. We can't just ask them of the knowledge they needed to solve problems. We need them to solve problems. That's how we know if we got there. Actually, this becomes the definition of this. Knowledge or the assessment actually defines the target. And this is a very important concept to keep in mind as educators, I believe, that the importance of clinical context for assessing competence in medicine results mostly from this. Assessment drives learning. Students all over the world, no matter what age, will try to learn what you want them to learn. If you ask them about solving cases, they will approach the learning material in a way that helps them to solve cases. If you just want them to recall data, they will approach the material with that philosophy as well. So if you tell them that you are going to assess their ability to solve problems, they can compensate your lack of dedication to the first target. As a trainee, I can look through a purely theoretical text and still see how would I apply this in practice if I know that you're going to ask me that, right? If I don't, then I will just learn it to recall it. So we can improve our teaching methods in order to include the clinical context, but at least we need our assessment to be able to focus on that level, because then the students will try to comply with that. Everyone wants to succeed naturally. So in order to do that, again, we come to Bloom's taxonomy. Our questions need to be set at the level of our objectives. If we only make questions in this, that's what people will learn, and this is not what we are targeting. So we need questions that represent the application of knowledge, the analysis of cases, of data, and even the evaluation of pros and cons, of hierarchization of solutions. This is better than that one, and that one is better than the third. And this is all evaluation, sophisticated use of knowledge. So when we decide that we need to do that, even EULAR has already in the guidelines this statement: for all clinical modules, the majority of questions will be case-based. Feedback on the reasoning behind the answer, and I would stress here as a convener, and based on my experiences, behind every answer, right or wrong, should have a reasoning why it's right, why it's wrong, will be made available. Let's say if I was the only one to make these decisions, I would not say the majority of questions, I would say all questions. Because again, I don't know of any knowledge that is useful if it's not applicable to solving some problems. And this is again interesting, because sometimes some conveners have asked me that, well, I want to test them on knowledge that is not so easy to make applicable in practice. I don't know how I could conceive a clinical case where that knowledge would be required. If this is the case, I answered him, you should be asking yourself whether that knowledge should be in your module. If you as an expert cannot conceive a case where this knowledge is applicable, why do you have it there, for God's sake? Aren't you trying to educate problem solvers? You're not trying to educate, ultra specialists, encyclopedists in medicine, right? Dr. Watson, the computer-based program, will be much, much better than you in remembering things, for sure, right? So we've lost that battle. So what is a case-based question, I would ask? Is it a question about material that it can eventually be applied to the solution of cases? Now, I've had that argument as well with some of my authors. They say, well, this is case-based because people can use this knowledge to resolve cases. Can you build up one? I don't have to do that. They will find it. Is this a case-based question? Is a case-based question questions about a case? Let's say I'll give you let's say a short description of a case, and then I ask you things that might be applicable. Like, consider Mrs. A, she has had pain in her knee and she has a weakness in her right leg. And considering this case, please tell me, which are the lumbar roots that serve the lower limbs? Is this a case-based question? I just have the stem having a clinical case, and then I make question about that. Questions on topics related to a case. This is what I just simplified. Or should we consider a case-based question a question that requires the application of knowledge to resolve a case? I think this would be the most comprehensive definition of what we should have in mind. I expect my learner to mobilize the knowledge, use it, transform it, compare it in order to resolve a case. Some interesting interactions with some authors. There was one particular author to whom I asked, can't you please transform this into a case-based question? And imagine that the question was, which of the following statements is true about disease X? A, B, C, D. And the author sent it back to me with this. A patient comes into your office and asks, doctor, which of the following statements is true about disease X? Now, are you joking? It's about you joking, right? It's not, of course, this is not what we mean. You need to apply knowledge to resolve cases. And if you're going to do that, in my view, so how to write excellent clinical vignettes for learning and assessment, my main advice for you is that please focus on the process and not on knowledge. Please focus on the process that takes place in your mind when you're trying to resolve a case, not really on the knowledge that is there, allowing people to use it. Focus on how do you think as a clinician? How do you approach a case? What kind of information you mobilize, and how do you compare it? How do you check it? How do you appraise that information? And consider what knowledge and wisdom have you mobilized and how to be able to sort that out. So not only the knowledge, the process is the most important thing. Now, if you look for advice, for instance, in the guidelines for authors themselves from EULAR, this is an example of a case-based assessment. And it says, the case begins with some general extended matching questions concerning presentation history of arthritis. Match the clinical stories or histories of patients with arthritis, that's 1 to 3, the 3 stories here, with the most likely clinical diagnosis of arthropathies associated with characteristic patterns of joint involvement. These are the possible diagnoses. These are 3 patient histories with 6 to 7 lines. Do you believe that this is a good example of a case-based question? Well, let us see. It gives you the description of the case. It tells you, for instance, that over many years the episodes became more frequent and spreads also to involve the knee and the hands. Each episode affects just one joint every time. So it gives you the conditions for you to reason. Is this a monoarthritis? Is this a migrating monoarthritis? Is it acute or chronic? It doesn't give you the right words. It doesn't give you the summary. It gives you the clinical case presentation so that you then apply the kind of knowledge that you need to be able, what is the most probable diagnosis. I think this is a good example on how to do a case-based question, right? You have the cases, and then you have to make a short decision. Let us suppose, take this case here, a 6-year-old man developed relapsing attacks of acute arthritis in his 40s, initially affecting his forefoot, midfoot and ankle. Over many years they became more frequent, etc., etc. You can run into the risk sometimes, because you're trying to make this short, that you use the most appropriate words. You do a really short summary of a clinical case, because the patient does not present like that, right? He describes it in a different way. Be aware that when you use very, very short stems, you are doing one of the most difficult tasks yourself. You're summarizing the information. So if you keep in mind that this is also an objective that you have occasionally, not in every question, you can allow yourself to have a longer case so that people exert their ability to summarize information. Because in my view, this is an absolutely critical competence that we need to develop. Be able to look at a full-length story and say what is important and what is not. But if you want to check that, you may allow yourself a longer stem than this one and explore that capability. Now, a second example tells you a previously fit 36-year-old woman presents with a 3-year history of intermittent pain and stiffness affecting multiple joints in her back. From the following list, select the 3 features in the history and examination that would most strongly support a diagnosis of psoriatic arthritis. And then you have a number of features. Is this reasonably case-based? How do you think? Would anyone criticize that as not being case-based and not being resolving a problem? I believe is fair. Now, in the same example, the next example says, which 4 of the following features are characteristic of the radiographic features of psoriatic spondyloarthropathies? And then you have one, for instance, targeting the big toe intercarpophalangeal joint of the foot, targeting the first metacarpophalangeal joint of the forefoot, non-proliferative marginal erosions in synovial joints. Is this application of knowledge? Do you believe? I think this is just simple recall. Simple recall of clinically relevant information, but I'm not mixing it to anything else. How could I transform this into a case-based questioning? Any ideas? I'll show you another question from the same set. What they have done, they have put up these pictures. What if I made the same stem, which 4 of the following features are characteristic of psoriatic spondyloarthropathies, and I have 4 or 6 or 7 images and ask them, pick them up. Now I'm asking this person to be able to look at a radiograph and identify features and put his knowledge of what is typical of psoriatic arthritis and mix them together, as if I would be doing it in my clinical practice. Am I right? In my clinical practice, bring me the X-ray. Yeah, this is okay, because it fits. This fits, that fits, that fits, that's fine. That's how I do it. So I need to look at the X-ray, make a summary myself, combine that with my knowledge about the disease, make the differential, and I believe that diagnosis is, let's say, a result stronger or is weakened or questioned by that. Another question, a diagnosis of psoriatic spondyloarthritis is made. Finally, some general questions about the named condition. Question 5, more than 80% of patients with psoriatic arthritis are HLA-B27 positive. The pathology of psoriatic spondyloarthritis mainly targets extrasynovial joint tissues, entheses, capsular ligaments. Patients with extensive psoriasis are at the greatest risk of developing psoriatic arthritis. Is this a case-based question? Not at all. Again, how could I transform this? Of course, it's sometimes difficult, even as a convener, to try and pick all the items here and provide the author with a good clinical-based question that covers everything, because there are so many different things, from HLA-B27 to how effective methotrexate and cilazoparin are in the peripheral involvement. But one could consider, for instance, a question like this. A 56-year-old male is sent to you by a colleague who suspects of psoriatic spondyloarthritis. You collect a full history and physical examination and read the available exams. Which 3 of the following observations would argue against that diagnosis? Right? Then you are taking the information that you're given, HLA-B27 negative, an ultrasound shows extraarticular involvement. The patient has no history or evidence of psoriasis, and you need to have the information that is not an absolute requirement that you have psoriasis for you to have psoriatic arthritis, so that you put it into context and understand that this does not exclude the diagnosis, right? So you are using and judging information to resolve a case. In this particular set of questions, the authors were obviously also interested in epidemiological aspects. What is common, what is not common, what is the associations between psoriatic arthritis and the type of skin involvement. Now you might consider your question like this, epidemiology. Incorporating with a colleague dermatologist, you decide to try and look in their database for patients who most probably have undiagnosed psoriatic spondyloarthritis. Which of the following criteria would you use to select patients in trying to enrich your sample? This is a clinical problem. Yes, you may face that. It's not a patient, but it's a clinical problem. So then you put in whatever epidemiological concepts you want to put here. And you again are asking people to mobilize the knowledge, be critical about it, and apply it, instead of just recalling. I have just a couple of other examples I'll go through very shortly. A patient with osteoporosis under regular alendronate treatment has been proposed a dental procedure for a root canal. You get excited. This is a clinical stem. Then the question comes, from the following statements about osteonecrosis of the joint, select the 2 that are correct. ONG, occurrence during bisphosphonate treatment, is very rare. Blah, 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 blah. Is this a case-based question? No, you just put a clinical stem in the top. You're fooling yourself, right? But this is not what you mean. Okay, another one. A 55-year-old female, previously healthy, presents with a 6 months history of pain in the lateral aspect of both wrists, more intense on the right. She cannot recall an obvious acute precipitant. The pain gets worse during daily gripping activities. Which two of the following represent likely possibilities in the differential diagnosis? Is this a clinical-based question?
I would say one.
Sorry?
Why not one?
One. Oh, yes, well.
Rephrase it as one.
Okay, they have two in this particular case, but you cannot use two anymore, right? It's only 1 in 5.
We learned that you should not make a question like this. I think it's better to, I don't know why, but this
Yeah.
has come from the educationalist, make it one. Make it one.
Yeah, 1 in 5 is probably more reliable than this.
Exactly.
Previously, we had the possibility of having 2 in 6 or 3 in 7. Now it's 1 in 5. But let's say, what I am targeting your thinking now is whether this can be considered a case-based question. Do you agree with that? It gives you a clinical scenario and asks you to reason about it. To apply your knowledge about what these look like to see how well it fits with the case. This is a good clinical-based question, I think, from that standpoint only. Another one takes the same case and then asks you, in addition to physical examination, you organize some investigations for the above patients. Which two of the following would be appropriate first choices? Is this case-based question? You need to know about the conditions, consider your patient, and make your choice. I think this is fair. Another one, with regards to polymyalgia rheumatica, which one of the following statements is false? Patients are generally over than 50. Patients have bilateral aching and stiffness. Is this a case-based question? Not at all. Can you conceive ways of transforming it into a case-based question? For sure, not necessarily with these 5 options, right? Maybe you need to rephrase it a little bit, but you can easily imagine a case where you need to mobilize this information to make a decision. You can even have the options like that. For instance, with the stem saying which of the following aspects would question the diagnosis or would support the diagnosis, or would you make you think of something else? Never mind. Then you can have the same hypothesis there. But again, you are using information in a way that means application, clinical reasoning, and judgment about it. And this, I think, is what we should be targeting. Any questions that you'd like to raise on this?
When you look at taxonomy, the Bloom's taxonomy,
Yeah?
and you go up to evaluate.
Yes?
So that's for residents or final year training rheumatology residents.
Yes.
When you consider medical school undergrad students, up to which part will you go up?
I agree with you. So the question that is being raised is, should we, let's say, also include, for instance, evaluate to undergraduate students? I would think that to a lower level of demanding, right? Yes. I think that it still should be there. Because you could, for instance, ask your student, and I think it would be appropriate, would you go for an MRI or a CT scan in looking for spondyloarthropathies, for instance, right? And you ask them, tell me why. You appraise the advantages and the costs and the risks and whatever, right? So to a certain extent, I think it's also applicable to undergraduate students. But of course, the complexity of the cases should be smaller, less detail being taken into the decision than at a specialist level. But I think that you should still target there. Even in undergraduate knowledge, teaching, from my view, we should not have questions that are just targeting this, remembered. And yet, this is the most common kind of question that we get, even in this online course. This is the most difficult aspect of the courses, you see. That's, to be honest, in my 15 years as a convener, I think that we have done a great job in the texts, in the revisions. We have done an excellent job in the in-depth discussions, not so good in the interactive clinical cases. And I think that we have come to realize that assessment was the weakest link in what we were doing. And even very, very experienced teachers, find it difficult to do. So you need training. Not that a long training. I think there's need a shift in your mind from knowledge to process. From knowledge to process. And this is the important thing. And we can achieve a lot. I think that everyone can do a good clinical case question if you decide to do it and if you change your frame of mind a little bit. Please.
I was thinking whether having the online courses by topics, as you said at the beginning, by diagnosis, is more difficult even, because you already know what the answer is going to be.
Yeah, now say for the diagnosis, if you are addressing the module on SLE, you can't have other diagnosis, right? You know that it will be for sure around that. But it would mean I would really favor that, but it would mean a deeper transformation into teaching and into our minds. I've written, on the basis of that first slide, I've written a book for undergraduate students trying to convey that from symptoms to diagnosis. And you need to go through contexts like big scenarios, like low back pain, and you address low back pain and not really, the diseases that give you low back pain. But I think it's one step further.